Hi, let's talk about nephrotic syndrome. So what is nephrotic syndrome and why should you care about it? Nephrotic syndrome is a kidney condition where you lose massive amounts of protein in the urine, specifically over 3.5 grams per day. Remember, nephrotic with O like protein. This protein loss leads to low albumin in the blood called hyperlipidemia, specifically less than 3 grams per deciliter. This syndrome also includes hyperlipoproteinemia, so elevated levels of lipoproteins and fats. Nephrotic syndrome may occur in patients with chronic kidney disease, like diabetic kidney disease, with an increase in proteinuria over time. But there can also be acute reasons like glomerulonephritis of different kinds. How is this different from nephritic syndrome? Note that nephrotic syndrome is not the same as nephritic syndrome. Nephritic sounds like inflammation and is typically characterized by more blood and less protein in the urine in contrast to nephrotic syndrome. Plus, hypertension and reduced kidney function is key in nephritic syndrome. Let's look at the glomerulus so you understand how proteinuria happens in nephrotic syndrome. Normally, you excrete only about 150 milligrams of protein in your daily urine. There are kidney conditions like diabetic or hypertensive kidney disease, which are very common and lead to damage of the glomerulus and specifically the podocytes. They play a key role in keeping protein in the blood. This is blood in the vessels. Next is the endothelial layer making the vessel's wall, which has small pores called fenestrations. Then the next layer is a basement membrane made of collagen and other proteins. And on top of that are podocytes, which are epithelial cells with little foot processes. And over here, this is where the ultrafiltrate forms and is going to become the urine in the end. Protein can enter the filtrate and be found in the urine in massive amounts when there is damage to this filter and especially the podocytes. They have little feet which are going to efface, meaning flatten out in nephrotic syndrome, making room for protein to enter the filtrate. So what specifically causes this damage? Let's start with so-called secondary causes. You already know diabetes and hypertension as common types of chronic kidney disease. When these types of CKD aren't treated very well, proteinuria may increase over time and can lead to nephrotic syndrome. This happens due to too much glycation in diabetes or sclerosing processes in hypertensive disease. Diabetes and hypertension are considered systemic or so secondary, since the kidney damage is a byproduct of these diseases. In contrast to these, primary renal causes can be differentiated. In primary causes, there is also podocyte damage happening, but due to a specific glomerulonephritis. In the end, they are differentiated by the look under the microscope from biopsy, and typical glomerulonephritis with proteinuria includes minimal change disease, focal segmental sclerosis called FSGS, or membranous GN called MGN. They may be primary, so without any other disease being present in the body, or could also be secondary again as a result of processes in malignancy like lymphoma or infections like hepatitis B and C, or even lupus erythematosus. The classification can be complex. You should remember there are chronic conditions where a threshold of nephrotic syndrome can be crossed, and there are acute reasons like glomerulonephritis. With this in mind, how can the symptoms in nephrotic syndrome be explained? The massive loss of protein is mainly albumin. This leads to a reduction of albumin in the blood called hypoalbuminemia. If you want to learn more about this topic, check out our video over here. But also other proteins are lost, leading to different problems. Let's start with albumin. The loss of albumin leads to the formation of edema. Typically, edema forms around the eyes, so periorbitally. But also leg edema may occur, and ascites, so water in the abdomen, may appear. And since the liver produces most blood proteins, including albumin, it notices the drop in albumin in serum It tries to compensate the loss in protein by increasing the amount of lipoproteins, which carry fats, since they also can attract water. And that's why hyperlipidemia, so also an increase in fats like cholesterol in the blood, are a criterion of nephrotic syndrome. Unfortunately, these lipoproteins, including lipids, may also be peed out, and this is called Lipiduria, which can be seen under the microscope. Typically, a cross-like structure called Maltese cross may be seen. Let's move on to other complications. Also, antibodies, so immunoglobulins, and complement factors may be lost in the urine, and this may lead to an acquired immune deficiency, and patients in nephrotic syndrome are therefore at higher risk for serious infections. The last complication you should know about is thrombosis. There's an increased risk of thrombosis, especially in the legs, called deep vein thrombosis, or in the lungs, so pulmonary thrombosis. These are in general the most common locations for a thrombosis, but in nephrotic syndrome, another typical place may be the renal veins. Why is that? The blood consists of anti- and prothrombotic proteins, so proteins that benefit thrombosis formation and those that inhibit them. Anticoagulant proteins like antithrombin 3 are lost in the urine because they are smaller, while the liver produces more prothrombotic factors like fibrinogen and factors like 5 or 7. This creates a hypercoagulable state. This creates a disbalance in the blood, which is most significantly shaped in the renal veins since protein has been lost in the urine. Let's summarize the key points of this video. First, nephrotic syndrome is defined by massive proteinuria, typically over 3.5 grams per day. It also includes hypoalbuminemia, so albumin less than 3 grams per deciliter in the blood, edema formation, and hyperlipidemia. Normal protein excretion is less than 150 milligrams per day. Second, the syndrome results from damage to the glomerular filtration barrier, specifically the podocytes, with food process effacement allowing massive protein loss. Third, albumin loss is central, but immunoglobulins and anticoagulant factors are also lost, leading to infections and a hypercoagulable state with increased thrombosis risk. And fourth, major complications can occur like edema, venous thromboembolism, especially in renal veins, and severe infections due to the loss of immunoglobulins and complement factors. Fifth, causes can be primary, like minimal change disease, focal segmental glomerulonephritis, and membranous glomerulonephritis, or secondary due to diabetes and hypertension, or in secondary glomerulonephritis due to hepatitis B and C, or malignancy. I hope this video was helpful to you. Consider subscribing, and I'll see you in the next video.